everyone, welcome back to my channel. Today we're going to talk about the physical examination, one of the most essential skills in clinical practice. Physical examination uses 4 basic techniques: inspection, palpation, percussion, and auscultation. Inspection means observing a patient's appearance and any visible abnormalities. Palpation is using the hands to feel for tenderness, temperature, or organ size. Percussion involves tapping on the body surface to determine whether the underlying area contains air, fluid, or solid tissue. And auscultation means listening with a stethoscope to the heart, lungs, or abdomen for normal or abnormal sounds. In this video, I'll introduce the different systems of physical examination and how we usually approach a patient from head to toe. Before any physical exam, there are a few important steps. First, always wash your hands. Then introduce yourself clearly, stating your name and your role. Confirm the patient's identity by asking for their name and date of birth. Next, explain what the examination will involve, obtain the patient's consent, and make sure their privacy and comfort are maintained. Finally, ask if the patient has any discomfort before proceeding. Now let's go through each system of the physical exam. Let's begin with general appearance. The first thing to note is the level of consciousness, whether the patient is fully alert, drowsy, or confused. Next, look for signs of distress, such as labor breathing or obvious discomfort. Pay attention to personal hygiene and grooming, which can sometimes reflect overall health and self-care ability. The facial expression may also provide clues, for example, pain, anxiety, or sadness. Observe the posture and gait, since the way a patient sits, stands, or walks can reveal underlying musculoskeletal or neurological problems. Check the skin color because it can give important clues. Pallor refers to paleness of the skin and mucous membranes, which may suggest anemia or poor blood flow. Cyanosis is a bluish discoloration often seen on the lips or fingertips, and usually indicates low oxygen levels in the blood. Jaundice is a yellowing of the skin and eyes, caused by elevated bilirubin, often due to liver disease or bile duct obstruction. And finally, take note of the patient's height, weight, and body build, which may indicate undernutrition, obesity, or other chronic health issues. Next are the vital signs, which give us a quick snapshot of a patient's overall condition. Body temperature shows the body's thermal regulation and may indicate fever or hypothermia. It is normally around 36.5 to 37.5 degrees Celsius. Heart rate or pulse reflects cardiac activity and circulation. The normal range is 60 to 100 beats per minute. Respiratory rate indicates how well the patient is ventilating, normally 12 to 20 breaths per minute. Blood pressure represents the force of blood against the arterial walls, with a normal reading around 120 over 80 millimeters of mercury. Oxygen saturation, or SpO2, shows how effectively oxygen is being carried in the blood, and should be above 95% in healthy individuals. Next, let's look at the neurological examination, which is performed whenever we suspect involvement of the nervous system. This includes cases of altered consciousness, headache, seizures, trauma, stroke, infections, or when patients present with weakness, numbness, or coordination problems. We start with the Glasgow Coma Scale, or GCS, a quick tool to assess consciousness based on eye-opening, verbal response, and motor response. Next is mental status, where we check orientation, memory, attention, and language to evaluate higher brain function. Then we move on to the cranial nerves, 12 pairs that control functions such as smell, vision, eye movement, facial sensation, facial expression, hearing, swallowing, and tongue movement. For motor function, we look at several components: tone to see if the muscles are normal, rigid, or spastic; power or strength graded from 0 to 5; reflexes such as the knee jerk or ankle jerk, which can indicate upper or lower motor neuron problems; coordination tested with movements like finger to nose or heel to shin, which reflect the patient's cerebellar function; and gait, which shows how well the patient can walk, including tandem walking for balance. For sensory function, we check different modalities: light touch with cotton, pinprick with toothpick, vibration with a tuning fork, and proprioception, the sense of joint position, tested by moving a finger or toe up and down with the patient's eyes closed. All of these together give us a comprehensive picture of the nervous system. Next is the HEENT examination, which stands for head, eyes, ears, nose, and throat. Starting with the head, we observe the overall shape and contour to detect abnormalities such as asymmetry or deformities. We also look for signs of trauma, scars, or skin lesions, and check the hair distribution and texture, which can reveal nutritional or endocrine problems. For the eyes, we assess pupil size and their response to light, which helps us evaluate cranial nerve function and possible brain injury. We test eye movements in all directions to look for nerve palsies or muscle weakness. The conjunctiva is examined for pallor, which may suggest anemia, and the sclera for icterus, which indicates jaundice and possible liver disease. For the ears, we begin with inspection of the external ear for redness, swelling, or deformity. Palpation can reveal tenderness over the mastoid, which may indicate infection. Then, with the otoscope, we examine the ear canal and tympanic membrane, looking for inflammation, fluid, perforation, or scarring. For the nose, we inspect the nasal passages for congestion, swelling of the turbinates, discharge, polyps, or septal deviation, which may contribute to breathing problems or recurrent infections. Finally, for the throat and oral cavity, we check the lips and tongue for ulcers, dehydration, or cyanosis, and the teeth for dental caries or poor dentition, the tonsils for enlargement or exudate suggesting infection, and the oral mucosa for pallor or ulcers. Next, let's go through the lymphatic system. Palpating lymph nodes is important because enlargement can signal infection, inflammation, or even malignancy. We usually check 4 key regions: the cervical nodes, the supraclavicular nodes, the axillary nodes, and the inguinal nodes. When palpating these nodes, we note their size, tenderness, mobility, and consistency. Next, let's go through the cardiovascular examination, which is indicated during chest pain, palpitations, shortness of breath, syncope, or swelling of the legs. It usually follows the order of inspection, palpation, and auscultation. On inspection, check the jugular venous pressure or JVP by observing the internal jugular vein in the neck while the patient is reclined at about 45 degrees. This helps assess right atrial pressure and the overall fluid status. We also check for signs of infective endocarditis or IE, such as splinter hemorrhages or Osler's nodes. Look for edema by pressing over the ankles or shins. Pitting often points to heart failure or fluid overload. We also assess perfusion with capillary refill time, which is normally under 2 seconds. On palpation, we begin with the pulses. We check them in several sites: radial, brachial, carotid, femoral, popliteal, posterior tibial, and dorsalis pedis. For each, note the rate, rhythm, volume, and symmetry. At the chest, locate the apex beat, which is normally felt in the 5th intercostal space at the mid-clavicular line. Lateral and downward displacement may suggest left ventricular enlargement. We also feel for heaves, which indicate right ventricular hypertrophy, and thrills, which are palpable murmurs from turbulent flow. Finally, on auscultation, we listen systematically over the aortic, pulmonic, tricuspid, and mitral areas, as well as the carotid arteries. We pay attention to the rate and rhythm, the heart sounds, and the presence of any murmurs, rubs, or extra sounds. Let's move on to the respiratory examination, which is performed when patients present with cough, shortness of breath, chest pain, wheezing, or suspected lung disease. It follows the order of inspection, palpation, percussion, and auscultation. On inspection, we observe the chest contour for deformities such as a barrel chest or a funnel chest, the spinal contour for scoliosis or kyphosis, and the breathing pattern for signs of respiratory distress. On palpation, we check for tracheal deviation, which may suggest tension pneumothorax or large effusion, assess chest wall expansion for symmetry, and feel tactile fremitus by placing hands on the chest while the patient speaks. Decreased fremitus can indicate effusion, and increased fremitus may point to consolidation. On percussion, we tap over the chest, which normally produces a resonant sound. A hyperresonant sound may suggest pneumothorax, while a dull sound may suggest pleural effusion or consolidation. We also percuss diaphragm excursion, which is how far the diaphragm moves during breathing. Decreased diaphragm excursion could be seen in conditions like pleural effusion, pneumothorax, lung collapse, or phrenic nerve palsy. Finally, on auscultation, we listen for breathing sounds, whether they are vesicular, abnormal, or abnormal such as crackles, wheezing, or decreased breathing sounds, which can help localize disease. Next, the abdominal examination is indicated in patients with abdominal pain, distension, nausea or vomiting, changes in bowel habits, or suspected liver, spleen, or gastrointestinal diseases. The general order is inspection, auscultation, percussion, and palpation. This is slightly different from other systems because percussion and palpation may disrupt bowel sounds. On inspection, check for signs of cirrhosis such as spider angiomas or capumedusa. Inspect abdominal contour for distension and skin for scars and striae or stretch marks. On auscultation, we listen for bowel sounds, hyperactive in obstruction or absent in ileus, and check for bruit or abnormal vascular noises over the abdomen, which may suggest turbulent blood flow due to conditions such as renal artery stenosis or abdominal aortic aneurysm. On percussion, we estimate the liver span to check for hepatomegaly. We also check for splenomegaly by percussing the left upper quadrant. Assess ascites by looking for shifting dullness. Fluid in the peritoneal cavity will change the percussion note from dull to resonant when the patient turns to the side. Finally, we percuss over the costal vertebral angle or CVA at the back. Tenderness here is a classic sign of kidney infection, such as acute pyelonephritis. On palpation, we begin with light palpation, gently pressing over all quadrants to check for tenderness, guarding, or superficial masses. We then move to deep palpation, applying firmer pressure to feel for deeper structures. We also test for important clinical signs. Rebound tenderness suggests peritonitis. McBurney's point tenderness is a classic finding in appendicitis, and Murphy's sign, pain on inspiration during palpation under the right costal margin, suggests cholecystitis. These findings are clinically important because many of them point to conditions that may require urgent surgical management. Let's move on to the musculoskeletal system, which we usually subdivide into regions: the back and spine, shoulder, elbow, wrist and hand, hip, knee, ankle, and foot. For each region, the exam follows a similar pattern. We begin with inspection, looking for rashes, edema, muscle atrophy, deformity, or surgical scars. We then move on to palpation, checking for warmth, swelling, and localized tenderness. We test the range of motion, both active, where the patient moves the joint, and passive, where the examiner moves it. Limited or painful motion can point to joint or soft tissue pathology. We also assess motor function and sensory function, especially when nerve involvement is suspected. Finally, we perform special tests tailored to each joint. For example, Lockman test at the knee to assess for the integrity of the anterior cruciate ligament. Neers or Hawkins test at the shoulder to check for shoulder impingement. And Tinel's and Phelan's test at the wrist to diagnose carpal tunnel syndrome, caused by compression of the median nerve. Finally, there are specialized examinations which are carried out in specific clinical situations. The thyroid exam is done in patients with suspected thyroid disease, for example, goiter, hyperthyroidism, or hypothyroidism. We inspect the neck for swelling, palpate the thyroid gland for size, nodules, or tenderness, check whether it moves on swallowing, and sometimes listen for a bruit. The breast exam is indicated in breast pain, lumps, nipple discharge, or as part of cancer screening. It involves inspection for asymmetry, skin or nipple changes, and palpation of the entire breast tissue and regional lymph nodes for any masses or tenderness. The pelvic exam is performed with women with pelvic pain, abnormal bleeding, discharge, or as part of the routine gynecological screening. It includes inspection of the external genitalia, specular examination of the cervix and vaginal walls, and bimanual palpation to assess the uterus and adnexa. And that wraps up our video on a broad overview of different systems of the physical examination. In future videos, we'll go into more details on some of the major systems. If you found the video helpful, don't forget to hit the like button, as it really helps the channel reach more people. Thanks for watching, and I'll see you in the next one.